Yes,
please.
I'm fine. Yeah.
Yes, please.
So, good evening, one and all. It gives me immense pleasure to welcome you all back to our Advanced ART Masterclass. This time we have a pioneer with us. We are so humbled that Madam has accepted our invitation to be here tonight. Before Vasundara ma'am invites our esteemed guest for today, I'll just give a brief introduction about the certificate course that we are starting. Two certificate courses. One is Genetics and Infertility, which is going to be a 12-week online course. We are doing this in association with TAPISAR, which is the Tamil Nadu and Pondicherry chapter of ISAR. And we are also introducing a reproductive immunology course, which is an 8 weeks online course. We will have one class per week and it will be for 8 weeks. So it is going to start shortly. For further details, please uh, call the number or click on the link. We will be sharing it in the Scale WhatsApp group as well. So with that, Vasundara ma'am, I kindly request you to introduce Nayana ma'am. And the next Advanced ART Masterclass is on 25th September, which is going to be the part 2 of the receptor polymorphism by Ramaraj sir. And October Embryology Masterclass is going to be by Dr. Ved Prakash.
Thank you, Sindhu. Welcome, good evening, and welcome to all the delegates present here. I am very honored to invite Dr. Nayana Patel, Madam. She's a well-known figure and a mentor, teacher to many, trained many students, and she's quite popular among all of us in India and also abroad. But I need to, mention few of our accolades, which, has come after years of experience. Madam is the medical director of Akanksha Hospital and Research Institute and Zivia chain of IVF centers. Her field of interest is regenerative medicine, gut microbiome, ovarian and endometrial biomarkers, and PCOS. Great achievement of 1740 surrogate babies born till May 2025. Madam is a state president of Obs and Gynae Society of Gujarat, founder president of Gujarat chapter of ISAR, and Madam is an invited, TED Talk speaker, Oprah Winfrey Show, Josh Talk, Hard Talk. Really a great honor. She has authored many research papers, written chapters, published and edited her own book, Advances in ART, reviewer of JHRS, JHRM, JAR, Human Fertility, and TNF Online. Madam has published and treated the world's first case. It's been published in the CERM journal, and Madam has published the first pilot Strium patients in Journal of Regenerative Medicine. I'm the pioneer of regenerative medicine in ART. Over to you, Madam, for taking us through regenerative medicine in ART. Welcome you, ma'am.
Thank you, Vasundara, for that wonderful introduction. And good evening, everyone. I would like to congratulate Vasundara for doing such wonderful work and giving education, being so passionate about it. And when she told me, I had no answer but to say yes. So, without wasting any time, I will be starting the talk on regenerative medicine, which many consider as hope and many consider as hype. So let us see how we go about, right? So we know that there is limitation when it comes to the treatment of ART. IUI, IVF, ICSI, donor egg, surrogacy, donor sperm, donor embryo. But there are couples who would not want to go for donor eggs or sperms, even though they are unable to produce functional gametes, and may also not want to go for surrogacy, but carry their own child. And then the science is limited when it comes to plain surrogacy or simple IVF when the follicles are really poor or sperms are really bad and the endometrium is not good. So here comes the role of regenerative medicine. This is a process in humans where the lost or damaged specialized tissue is replaced by proliferation of undamaged specialized cells. We have platelet-rich plasma, stem cells, and exosomes. So this is the preparation. I'm sure most of you will be knowing this preparation, ready-made tubes are also available with calcium gluconate, but we plan to prepare it always manually. And there are 2 rotations of 1200 time and then second. I can share that full protocol. When your rotation is done for the first time, you take out the supernatant, again you rotate it, and then again you take out the liquid. The fluid that you take out will remain, and you will dilute the pellet. But before you do that, you will take a drop from it and find out the platelet count. Normally, I'll tell you the inclusion exclusion, but here the original platelet count should at least be more than 1.5 to 2, 100,000 or 2 lakhs. Otherwise, the yield will not be so great. We are looking at 3 to 5 times of the original platelet count. So we are targeting something between 9 to 12 lakh platelets per ml. And that is the ideal preparation which we need to inject it wherever it's in the ovary or it in the endometrium. So I ask you all to go through this beautiful publication where they've said that if the autologous platelet-rich plasma is not prepared properly, there will be conflicting and limited whatever we say the evidence is. Some people will say that no, it is not effective. Someone will say it's effective. So it is dependent on how you select the case, how you prepare. The preparation technique is very, very meticulous, good preparation. There are people who order a pathologist to prepare it, or the patient carries it with her and sits in the OPD and then you do it. No, because this has to be properly prepared. It should be under you. It doesn't take much time. 45 minutes, even you have those calcium gluconate added vials where you can, tubes, which you can centrifuge it and prepare it. So please see that you prepare it properly, and please see that whatever platelet-rich plasma from wherever you are getting it, if you are not preparing, just check the count, not after dilution, before dilution, that it should show huge amount of platelets in it. At the same time, you should not only increase the platelet factors, see the leukocyte count with it. We want pure platelets as much as possible. And the activation part is the most important part. You have received this vial of platelet-rich plasma. Then you have to activate it before you ideally inject it in the ovary, in the endometrium, subendometrium, or testes. And what is that? When you activate it, if you have not added calcium gluconate, you need to activate it physically. That is, that vial is frozen in liquid nitrogen. Immediately it gets frozen. Take it out, allow it to thaw. Again, put it in liquid nitrogen. Again, take it out and allow it to thaw at the room temperature. What happens? This growth factors are there in the granules of the platelet-rich plasma. And when you give this physical activation or chemical, the granules will start rupturing. So when the granules disperse and rupture, the growth factors will come out, and it is potent only for 15 minutes. Best is between 5 to 15 minutes. So the patient is ready, prepared, and that is the time you ask the person to activate it, and then you just inject it. If it's lying there after activation for 1 hour, it's no good, it's waste, and that will not give you the result. So as I said, it is very important to do this. One minute. So go through this publication to get the exact idea that how your PRP should be prepared. It acts by anabolic effects, that is the growth factors are creating it, scaffolding effect because of the fibrinogen and anti-inflammatory effect mediated through inflammatory mediators. Next, we come to the stem cells, and they have the characteristic of differentiating into multidirectional, different type of cell lines. There is angiogenesis increases, immune regulation, and paracrine stimulation. Of the various stem cells that are available, we use the multipotent because it can differentiate it to only a limited range. Embryonic totipotent is not used, and these are known as the mesenchymal stem cells. We are using bone marrow derived, but adipose tissue is also there. Umbilical cord gives excellent result, but not allowed to be used in India. And even the menstrual blood can also give stem cells, and dental pulp also. We prepare from the bone marrow stem cells, and before the patient is once the patient is counseled and before the patient is put up for the procedure, there should be a proper audio consent, all paperwork. There are special consent forms that you need to sign. Then once the patient is admitted, we take blood 40 ml for platelet rich plasma, what we took before. The same type, because they say that even for 1 or 2 hours, you culture the stem cells in the platelet-rich plasma autologous, the potency of the stem cells increase. So you give them one antibiotic, 2 to 4 liter of oxygen for 30 minutes, give vitamin C IV and glutathione. And 1 hour later, you take the patient in the operation theater. We prefer to do it from the anterior or the posterior iliac spine. Nowadays, we are doing mostly anterior. A Luolock syringe, 80 ml, and which is attached to that needle, which is the bone marrow biopsy needle, and the bone marrow concentrate is aspirated. Ideal is 80 ml, but many a times the female may give 50 ml or sometimes 30 ml also. But whatever is there, we need to prepare the stem cells from it. Manual method, but these are the automated Sepex bone marrow separator, Angel bone marrow separator, which will separate. There are special kits like a blood, this thing. So when you collect the bone marrow and you send it, they are put in the kit, and then automatically the mesenchymal stem cells are separated. And for the platelet-rich plasma, when we do it manually, we use ACDA solution, which is from the blood collection that we have. There is ACDA solution, and from there we use it. So that is easily available, and it turns out to be even quite cost-effective. Now for the stem cells, when you prepare it, you have to culture it also, check for the infectious disease profile, and check for the contamination also, and then you start the procedure. And once it is done, again you check for the infectious and you see for the cells. You just count the cells, because counting the CD3473 is a flow cytometry and it cannot be done immediately. So how many million per ml? It is said the dosage is 1 million per kilogram body weight. So if she's a 60 kilogram female, maybe 30 you can inject in both the ovaries, but this much of cells to get from the bone marrow of an little adult woman sometimes is not possible. So whatever 15-20 million you can inject, but that cell count can be done immediately. Now, the advantages are that they do not raise ethical concern, they have limited immunomodulatory function and low immunogenicity. And the mesenchymal stem cells are multipotent, self-renewal. They activate number of Parker's pathways, and there are number of CD cells which are good and which are collected. They have a capacity to differentiate into osteoblasts, adipocytes, chondroblasts also, and they mainly function via paracrine signaling and regeneration. Now, how do we optimize? Because this treatment also gets a bad name if you are not using at the right time for the right person in the right dosage. Though nobody has so far been able to define that what should be the right dosage. So effectiveness depends on the disease stage. When you are taking the dose of the delivery, the stem cells you can give intravenous, but these intravenous are not helpful. Normally they get trapped in the lungs because there is microcoagulation over there. But if you give it in the targeted organ, it really helps. Or if you give intra-arterial, where the stem cells are surrounding that arteries, it will give good result. Patient genetics also because it cannot 100% or not even correct genetics, though they say that it can extrapolate, but it is not proven. Then the extent of response varies from patient to patient, and production method is very important. So it should be a tailored MSC therapy. Not all patients will need 3 times PRP or 3 times stem cells. No. Each patient, how it responds will decide when is the next dose, or if at all she needs a next dose. And then how do we optimize the MSC, pre, post, what treatment should be given. So these optimization strategies are still under study. Now, ovarian rejuvenation, we know, is one of the burning problems where we see POI very early nowadays and diminished ovarian reserve with the age. It will activate the regenerative therapies, the dormant primordial follicles, and alleviate even some of the hormonal effects which are there with POI and DOR. Previously, we thought that the males only can produce sperms till 1890, and females are born with a set number of oocytes, and then around menopause, they are all exhausted. But not anymore. Now we know that there is successful discovery, isolation, and establishment of ovarian stem cells, and this has given us the hope. So we need to now see how this ovarian dormant cells we can stimulate it to convert into folliculogenesis. For this, we have to understand what is ovarian stem cell nest and what is niche. Niche is part of the nest. Nest is composed of the granulosa cells, endothelial cells, and immunological relevant cells which surround it. And this ovarian niche is the key parameter to promote an adequate follicle development. And this is what we target with the stem cells or with the PRP to rejuvenate that ovarian niche, which will help in developing the follicles within the ovary. So this is the picture of the ovary, and you can see here that there are oogonias, that is the oocyte stem cells. And this on the HE stain you can see, and this is what we need to activate. And this is the typical picture of this niche. So how does it help? It helps by immunomodulatory effects. So we know everywhere the inflammation should go down. So TNF alpha will go down. There needs to be an antifibrotic effect. And when there is regulation of angiogenesis, good blood flow, we know that it will help the angiogenesis and the vasculogenesis. But the most important is the granulosa cell survival. We know that folliculogenesis and regulation of granulosa cell is very important. So we need to reduce, and that happens with stem cell or PRP, that there is reduction of apoptosis and atrosia of the granulosa cell. There is regulation of pro-apoptotic proteins and proliferation of the cells. So this is the main effect, and there are two more effects. One is the mitochondrial transfer, which is the latest in 2025 publication, and also the EV, extravesical secretion, where it helps by especially the exosomes carrying the proteins and lipids and miRNAs. All this time we thought that POI and DOR are the two main indication. But no, we have now made it little broader. When the patients have failed fertilization or poor fertilization repeatedly due to the quality of the egg, or there is low success of fertility in spite of the male factor, everything being normal. In recurrent miscarriages of unexplained etiology, especially when the AMH is low of the patient, whatever the age group, PCO, endometriosis, and post-chemotherapy. So now again, the same action which I said, that this is the mechanism. What happens is the PRP or the stem cell, especially the stem cell, they will go and home it. Homing in is what we call at the injured site. So wherever there is injury in the ovary, that is the granulosa cell, etc., surrounding that in the stem cell niche, the ovarian niche, the stem cells will go, they will home in. Once they home in and settle, they'll start differentiating into whatever cell. If it's the endometrium, it's that. If it's the ovarian stem cells, ovarian oogonias, it will go and proliferate the granulosa cells. So that is the beauty of stem cells, that there is differentiation into the whichever cell they go and home in. So this is a beautiful, again, a very recent paper from 2024, where they have explained that what is the pathological situation on POI and how MSCs will help it to take care of it. So first thing to reduce is FSH. So when you give treatment, after 3 months, assess the FSH on day 2, it starts coming down, and gradually the AMH will rise, which will not be very remarkable. It will act as reduce the oxidative stress also, and it will accelerate the growth of the follicle and anti-apoptotic factors. Now, the criteria is that we should always rule out the karyotyping should be normal. It should not be an abnormal karyotype like Turner's or XXX. We should be careful about it. We ideally do it for 21 now, we should say, or even young girls, we do it when it's not for infertility, but just to improve this thing. 18 to 40 years, up to even 45 years. Patients with secondary ovarian failure. But normally young girls means those who are in the range of 23, 25, who are keen to extend their fertility. This is not the ideal way, but at least we can preserve it if they are not ready for oocyte freezing or for ovarian tissue cryopreservation. Then the hypothalamic disease should be ruled out. In autoimmune, the effect is very short-lived. How long is the effect is a common question. So it could be 18 months is what we have seen also. It could be less than that also, how a patient responds. But in autoimmune, the response will be for a very short time, and we are still now started doing an autoimmune. Major medical problem or any hematological issue, we don't do it. The key consideration, when to plan. So when you have seen a patient immediately first low AMH, or we will not, even a 40-year 0.5 AMH, you want to try one IVF cycle without doing anything, just giving the supplements, lifestyle changes. But repeatedly it is low, we can explain, or IVFs have failed. Then what dosage? And what is the time? Not necessary do post-menstrual immediately. If the ovaries are very small and you cannot visualize on ultrasound, it's better to give an ovulatory agent and do it around 10th day. And even premenstrually also you can do it. There is no harm even if there is a corpus luteum surrounding it. You will find the cortex, you can do it. What dosage? So dosage, I say that the platelet as much as you can maximize. And this, see the volume of the ovary. So volume, if it is small, maximum you can give is 1.5 ml, 1.82. But if the volume is good, you can go even up to 3 ml in both the ovaries. Our ideal dosage is 2 ml. Whether to do transvaginally or laparoscopically, ideally it is laparoscopy, because under vision you can put it in the hilar or the anti-hilar. You can literally lift the ovary, and trans-abdominally you can also inject in the cortex with a spinal needle. We inject it with the egg retrieval needle. But the patient recently had a laparoscopy and does not want to do it. Ovaries are accessible. One thing, they should not be stuck. They should not be in an area where you can injure any organs, especially the ovarian vessels. So you have to judge all this prior. What precautions should be taken, proper aseptic, antiseptic, and the complications, how you can minimize, especially fix the ovary when you are doing it properly. Only when it is fixed and you try to inject, the ovary moves, better not do it transvaginally, post the patient for laparoscopy. Prognostic factors are mainly the age. Less than 40 gives the best result. We do up to 45. We have done even more. Second is the volume of the ovary. If the volume is good, at least there is something inside. The substrate is there from where the oocyte will grow. If they are very, very streak ovary, your counseling should be very thorough, that we are doing it, we don't know what is. For everyone, you should say, don't give a rosy picture. Then she had a past carriage, chemical, or IUFD, whatever it was, or as a living child, they are the best, because these are proven fertile eggs, whatever she has remaining also, because it has already given the pregnancy. And the counseling is the most important part. DOR, you can always say your IVFs have failed, it's better you go for donor egg, nothing like it. But if she still insists that I want my eggs, then is the time when you should counsel for this and say that it does not work for everyone. It may work for some, it may not work for some. We will do our best, but you should be well informed that this is not going to give you from 10 follicles from 2, or increase your AMH point from 0.5 to 2 also. AMH cutoff many people take, but I don't see that reason. 0.001 and 0.009, 0.004 has also given result. But what I say is the volume should be good. And these patients with very low AMH, almost irregular, very irregular cycle or amenorrheic, the counseling should be very thorough, that it is an experimental procedure. You may not get a result and you may end up with egg donation also. Now, transvaginally, you can do it, and laparoscopically. Transvaginally, it is quite simple. As I explained, you fill up the egg retrieval needle right up to the tip. The embryologist has proper measurement of what is there remaining in the length of the egg retrieval needle. Take just a little drop out and then start injecting. You should ideally first do a good scan and see where all spot. Maximum 2 punctures, I would say. And when you inject in the cortex, give 0.4 ml. Then ask the embryologist to, or whoever is pushing it, to stop a nurse. Count for 30, 40, 60 seconds. Allow that PRP or stem cell to disperse. Then move your needle a little bit again and go to another area of cortex. Again, allow 4.4 ml and allow it to disperse. Don't do it in a rush. You also count up to 60. Your assistant also counts. And that is the time. Very small ovary, you can stimulate like this and see that the follicle is growing and then inject. Otherwise, what happens? You inject from one puncture and from the other puncture, there will be the leakage. So fixing of the ovaries, deciding the points, everything should be very properly planned. You can see this was our previous technique, a very streak ovary, the hilar and the anti-hilar. You can see there was some leakage. So now we have shifted to this. You can see here, there is some leakage. This is what we used to do before. Now what we have started is, this is again with the egg retrieval needle only. Properly hold the ovary, go into the anti-hilar border first, slowly drop by drop inject and wait. Don't change the, don't puncture it again. Allow the cortex to totally ovary to get blanched. So that means the dispersion is where there is no leakage at all. And then go towards the hilar, anti-hilar, and then the hilar border. And there also you inject it like this. So there is no leakage of the fluid that you are injecting, whether it's stem cell or the PRP. So this is the picture before and this is the picture after. There are a number of publications with platelet-rich plasma, our Indian publications from abroad, which have shown that it helps. There is a systemic meta-analysis and review. Some are in favor, some are not in favor. And this is Sonia Harayas's paper on autologous stem cell ovarian transplantation. The study is still going on. They had 5 pregnancies and they were also injecting into the cortex. There is one study where they injected into the ovarian artery, but it is a very, very risky procedure to do it, and we don't do the ovarian artery. These are some of our Indian publication, and this is our publication in Fertility and Reproduction, the Aspire journal, how the PRP can help in ovarian rejuvenation. We had 45 patients, 18 were negative, but 27 positive, out of which 8 were natural. So we have seen patients whose IVF fails, and because there were 5 eggs, 3 day 3 only, and transferred and negative. And now we do PRP and we tell them to wait for 2 to 3 months. If they are young patient, you ask them to wait for 2 to 3 months, because ideal time is 90 days for the recruitment of the primordial follicle to pre-enteral and enteral. But if the patient is advanced age 41, 42, I would do it immediately in the next cycle. And post PRP or stem cell, we also give them DHEA, antioxidants, coenzymes, and all the supports, melatonin, omega-3 fatty acid, all that we supplement, and good nutritive diet also with magnesium, selenium, all that has to be counseled. And there were IVF pregnancies. So 27 patients had a positive outcome after the platelet-rich plasma therapy. So our conclusion was that it definitely helps. And this was the case where she is a 41-year-old. She was a judge from Himachal Pradesh, 0.54. We did PRP, they did IVF, and day 3 embryo, successful, healthy baby. And this was from a religion where she is not allowed to go for donor egg. Her AMH was 0.04.
Ma'am's video is frozen, Naman.
Madam's video is frozen. Yeah. Your video was
Yeah.
frozen in between. Yes.
And so we did this, and she conceived naturally. This another patient who had 0.09 AMH with 14 FSH. When FSH is high along with low AMH, possibility goes down. We did her bone marrow data. So which patient you do PRP, which patient you do bone marrow? PRP generally patients will have good PRP. Bone marrow for little advanced age is better. If the AMH is very, very low and the patient agrees, we go for the stem cell only. And if the patient has especially past history of very many failed fertilizations or this, we go for the stem cells. PRP we keep reserved for young girls only, or when the patient doesn't want to go for the bone marrow aspiration. She also had an IUI pregnancy and delivered. So after PRP or stem cell, you can do IUI. They can conceive naturally while they are waiting for 3 months. This patient, 41 year, 0.151. We did her in July. And then what she did, she was very, very educated in the science, life science part. So after 3 months, she went to US and did. She said, my follicle counts from 5 have gone to 9. FSH has dropped from 21 to 8.8. See the difference. And the AMH from 0.151 has gone to 0.696. So this is how you document your results. Now we'll get you a small study of recurrent pregnancy loss unexplained with low AMH. This patient had 2 failed IVF, 2 miscarriages, AMH 0.32. So after miscarriages, she went for IVF and then she was advised donor egg. She came to us. We did the bone marrow stem cell therapy with laparoscopy. She conceived naturally and delivered. Looking at her, her friend from USA, again 46-year-old, though her AMH was good 0.88, but she had 4 miscarriages, including 1 Downs. And the stem cell therapy, we advised her for donor egg. She said, I'll only go for at 48 years. Till then, I'll try. So she was 47 running. We did the same treatment and she conceived naturally and delivered. So what I say, the volume, the past proven fertility is very, very important, and she delivered a healthy boy. This is the unpublished data that we have of 51 patients, 27 positive, 24 delivered, 3 miscarriage, and out of this miscarriage, 1 more has conceived again. So endometriosis, it's definitely an inflammatory condition with lot of release of cytokines. And now they've said that there is experimental evidence in both animal and human models, mice as well as rabbit, where it has shown promising result for stem cell-based therapy for restoring fertility in endometriosis. So this is the workflow. This is the 2025 paper in the Journal of Ovarian Research by Nayana et al. And they have showed that how stem cells can help in endometriosis patient. This patient had come to us from Dehradun. She had 1 failed IVF, and they said the oocyte quality is really low and grade 4 endometriosis. So she didn't want to go for donor egg. So we decided to do her laparoscopic surgery to remove all the endometriosis, clean up the chocolate cyst. And in the same sitting, there are some people who are scared that why it will increase the inflammation there. If you put, it will be a good supply. No, understand it is as an anti-inflammatory effect. Whenever I'll talk about the endometrial fluid also, it's inflammatory, go and put PRP. So here after reconstructing the ovary, you can see we have injected the stem cells, right? And this is the last picture of the surgery when it was finished. After that, we called her in January. We got 5 eggs, all 5 fertilized. We just transferred 3 and she delivered a healthy baby. We still have her frozen embryos. Again, this patient from Delhi, 37 years, 2 miscarriages, last in 2019, 0.15 AMH, chronic endometriosis. We did the stem cell therapy for her. She conceived naturally, delivered healthy baby. PCOS again is an inflammatory condition. We know the follicular fluid will have lymphocytes and a high Th1 response, which is bad. We need a Th2 and Treg response. So there are now papers which are showing that human mesenchymal stem cells preserve the capacity to suppress human Th1, and that will reduce the internal inflammatory environment in PCOS. So from the same journal, they have a nice workflow that what are the pathways that are activated in PCOS patients and which will give the good results. And now I was surprised to see there are a number of clinical trials going on of stem cell therapy in the PCOS patients. And this publication from SERM, it's again 2025, showing that stem cell has potential effect in PCOS management, its hormonal balance, follicle development, antioxidant, anti-apoptotic, and it is an alternative to conventional treatment for metabolic complications also. It's a beautiful paper, clinical trials and further research needed. So this is one odd case, but we must have done right now close to even 30 to 40 patients or more in PCOS with good results. We are collecting the data and we just did drilling, and along with drilling, we put the platelet-rich plasma only. She conceived naturally and had a healthy baby. Ovarian tissue activation is another condition where you activate the primordial. When you do PRP stem cell, it is mostly the secondary follicles. Here it comes, the primordial follicles. Here it comes to the secondary follicles because immediately in the next cycle. So you prepare the patient with sequential estradiol, valerate, and norethistron. Once you stop, the next day to take the patient for in vitro activation, and the mechanism is disruption of the hyposignaling from promoting the folliculogenesis. So this technique is done. Here you can see. So once it is stopped, immediately the next day you do it. And 5 days later, when the washout and she gets a period, you start the stimulation because these are the secondary follicles already which are recruited. We are physically disrupting it. So you take the cortex, you take this tissue, and then I'll show you what they do in the lab. They cut it into 50, 60, 70, 80 small cubes. And once they are done, it takes almost 40 minutes. The procedure is still going on under the same anesthesia without any chemical treatment. But there's a special media, special knife to do it. It is injected just in the subcortex. You can see here, and then it is sutured. So this is the lab procedure. You can see how minutely each pieces are done and what maximum number of pieces. So you have to slice it, and you can literally see sometimes if there is an endometriosis, some endometrial fluid also coming out. And then this is put over here in a vial, and then it is taken in an infant feeding tube, and through the laparoscope, as I showed you before, it is injected. Now, Kawamura is the person who has done a lot of studies on it, and he has delivered in 10 years more than 100 babies. And these are the worst cases where the AMH is very low, severely, menstrual cycles have been irregular. And these are the patients only where we advise them EVA technique. The first case of EVA pregnancy in India was from our clinic, which was published in the Journal of Human Reproductive Sciences. It is drug-free in vitro activation. There is a patient who was 34 with 0.22 AMH. And we did the EVA technique, first case. So we didn't do in both the ovaries. We were worried. We did a stem cell therapy in both the ovary, in the left ovary, in the right we did this. And she had 3 good quality day 3 embryos. And we took the embryo eggs from the right ovary only where we did the EVA, but she had a miscarriage. Then she conceived naturally, and the corpora lutea was on the right side, showing that the ovary where we did EVA, the egg was released and the healthy baby was born. Thin endometrium also number of treatment, but what is the role of regenerative medicine? When nothing works, we have to think of regenerative. We need a good functional layer for the embryo to implant. If it is thin, we know that it is detrimental due to the high oxygenated blood flow. So mesenchymal cells can promote endometrial regeneration by enhancing cell proliferation and reducing fibrosis. And we know that the endometrial stem cells are located in the basal layer. And the endometrial stem cell niche, a very dynamic, complex, and heterotopic area changing its structures, is located in surrounding the basal spiral arterioles. Spiral arterioles, which are present in the basal layer of the endometrium, there surrounding it here, there are the stem cell niches. This is the vessel and so anything you put through this vessel will be directly attracted by the injured stem cell niche, and that is our target. And this is how the actions happen. All anti-inflammatory, paracrine secretion, angiogenesis, epithelial driven, and the outcome will be improved thickness and implantation potential. So in the treatment of intrauterine adhesions, we want something, and stem cells has been used now to reduce fibrosis repair the damaged endometrium as well as improve the receptivity. They can transdifferentiate into epithelial, endometrial, vascular, and endometrial stromal cells, the paracrine effect through exosomes and microRNA, and then there is the immunomodulation. Main is there is cytokine induction. So the endometrium is so damaged, there will be induction, and the stem cell will get attracted through the cytokines, the chemokines, and get homed into the stem cell niche. There it will start the growth factor production. There it will start the regeneration of the endometrial cells, because the stem cell niche has the capacity to develop into the endometrial cells, which goes into the functional layer. Growth factor production, natural killer cell activity reduction, Th17, Th1 decrease, and Treg and Th2 increase. Intrauterine instillation, subendometrial hysteroscopically and direct into the uterine artery spiral arterioles. So this is 0.5 ml. Whether you inject, we do PRP only. We do not do stem cell for this. So PRP, you take it, and 2 to 8 days before embryo transfer. If you are looking at the thickness, it should be done in the early follicular phase by 6th day. You can repeat it after 3 days. If you are doing for endometrial fluid also, repeatedly the patient has, then also it should start from early. But if the lining is good and patient is having repeated failure, in that case, you want to improve the receptivity, just do 2 days or 3 days prior to embryo transfer or IUI. And this is how we inject with the IUI catheter only. We now use even embryo transfer catheter. We fill up the bladder and abdominally we do the scan, and along with it, drop by drop, we put it maximum 0.5, 0.6 ml will go. But that also drop should go very slowly so that there is no leakage, and then only it will have a good effect. During hysteroscopy, we have developed a very good technique. We just clean up all the adhesions which are there. Then with the same egg retrieval needle, we inflate the cavity with saline. Ultrasound guidance is always needed. Once you go beyond the endometrium, that is submyometrial region, beyond the endometrium little bit, that is the place where you put, because you know that it is lying in the basal layer. So what you do is you fill the cavity and about 0.7 ml is injected in on the four walls, whether it's PRP or stem cell. Once you inject slowly that 0.7 ml, evacuate the full uterine cavity. Let the fluid saline come out. Let it get absorbed. Wait for about 30 to 60 seconds we wait. Again inflate the cavity and then change to the next wall, anterior, posterior, and both the laterals. So this is how you do. Along with the inflated cavity with saline, if you try to inject, there will be, it can come out with it. So this is what allow the walls to collapse. Let it get dispersed, again inflate the walls, and then you put it in the other walls. These are number of publications which are seen over here. And even Fertility Sterility has said that PRP can be useful in the patients where there is thin endometrium. This is our signature procedure which we do. Instillation into the uterine artery spiral arterioles, as I explained, because they have done experiments in the mice. So mice and humans both have same. The endometrium stem cell niche is located at the endothelium of the spiral arterioles in the basal. We were inspired by Carlos Simon, but he used only CD133. They gave 3 days of GCSF, and then they mobilized the bone marrow stem cells and they used peripheral blood, and 3 times they had to collect in a blood bag. So it is 300 ml of blood every time. And then they proceeded to develop this CD133 by plasmapheresis. But we don't need CD133. Actually, the bone marrow concentrate is ideal because it has all the CD cells which can help act in conjunction. And so we just took the bone marrow mesenchymal stem cell, separated it, and we injected, and it was again the transdifferentiation into stromal endometrial epithelial cells, immunomodulation, angiogenesis, antifibrosis, and anti-apoptosis. This is the lab, the OT lab and the cath lab where it is. For this, you need cath lab. So this is the cath lab. So once the patient is admitted in, these are the worst patient. In 2019 January, we started. Until date, we have done 55 cases, and that too not our own patients. There are referrals from Nepal, Bangladesh, all over India, Jaipur, Bangalore, Delhi, Mumbai, and till then we have done only 55. So these are not a routine case. Worst cases, tuberculous endometritis, they just have brownish discharge or totally amenorrheic. The lining doesn't go beyond 3-4. That also is fluid filled with repeated hysteroscopy, PRP, hysteroscopy, subendo PRP. Also, the patients have failed. And their menstruation, maybe one cycle they get good after hysteroscopy, again it goes to spotting and brownish discharge. These are the only patients which you take for this. You go from the femoral artery, catheterize it in the cath lab, and we see to it that one of us is always present from our team. So once your patient gets admitted, you collect PRP. After 1 hour, collect bone marrow, do your procedure, hysteroscopy, whatever you have to do. By then, the stem cells will get ready in an hour or 2 hours. Then you take the patient to the cath lab. And here they don't need anesthesia. Locally, the femoral area is infiltrated. And from right femoral artery, you go to the left uterine, internal iliac. From the left internal iliac artery, you try to negotiate the uterine artery. And then once you enter the uterine artery, you put in the microangiocatheters, the interventional radiologist or cardiologist. And once the microangiocatheters are passed, then the stem cell about 1 to 2 ml. Normally it's 1 ml that we put and very concentrated. After it is done, this is the fluorescent dye to confirm. They can see that it's passing around the spiral arterioles. So after the procedure is, after the stem cells are installed, we wait for some time and we inject it to prove that it has passed through this only, right? You can see that the spiral arteriole surrounding. So this is the procedure. Both the femoral arteries we do, we can find out sometimes there is an absent uterine artery, there is hypoplastic uterine artery on one side, or it is severely stenosed due to endometritis and you cannot negotiate the uterine artery, so you cannot pass the microangiocatheters. So this was our first child which was published in SERM, the first child in the world which was born through this therapy. This female had tuberculosis, was advised surrogacy. We did this uterine artery, spiral arterioles. You can see the changes hysteroscopic as well as the blood flow. We document all that. And then in May, we could get a good endometrium. We transferred and she has a healthy baby. The first case we did, we put the Leach-Wilkinson cannula to help the interventional radiologist. There is not a huge difference, but yes, you can see the post-therapy scan, even there was still a little fluid. This patient had one missed from Bangalore. She had 7 embryos frozen for 1 year, hysteroscopy, endometrial PRP, subendometrial, everything done. She was denied transfer, lining was not good. When she came to us, we did this procedure. And then she had a good flow in April. She menstruated. Then again, 3-4 days, the flow increased, the cycle flow. And the previous patient, till today, she has healthy menstrual flow regularly every month. Her tubes were blocked, her ovaries were almost very small, but the endometrium was prepared so that she could deliver a child. And then when she goes back to doctor in Bangalore, I said, what did your doctor do? This is a lovely writing. And she delivered twins. This is a case where she had only brownish discharge, very thin endometrium, point. There was one missed abortion. She had 2 cycles which were negative, 3 hysteroscopies before, and that's the time we did this procedure, uterine artery, and she delivered twins again. And this patient, she was sent, all these patients come to me for surrogacy, and then we explain to them if we see a hope for this procedure. She had 2 ectopic, 3 IVF, multiple leprohistro, Asherman syndrome, myomectomy, thin endometrium. August 2023, the boards were not formed. So we said that you have to wait, or we can try this procedure by the time you are waiting for surrogacy. She agreed. We did this procedure. She got a 7.5. We sent her to the clinic where her embryos were frozen. The doctor agreed to transfer and she delivered a healthy baby. So now we had 12 patients. Out of that, 2 we had refused, but they wanted 10 patients where we did this. And this is the first pilot study case series of these patients where out of that 6 had a result. And so we concluded that To a best of our knowledge, the case series of 10 patients in the world where BMDC was installed and through the uterine artery intervention, and the results were encouraging. Today, we have total 55 cases, 25 positive, 17 delivered, 4 ongoing pregnancy, 3 miscarriage. Out of that, again, 1 has conceived. The obstetrical complications, because the endometrium is thin, IUGR, oligohydramnios, we had 1 which was preterm delivery and 2 had obstetric hysterectomies. They both were from Rajasthan. And 1 procedural complication, when the interventional cardiologist was passing it through the internal iliac, it was so narrow that the dissection happened. Immediately, vascular surgeon was called and stenting was done. Patient is fine and we are preparing her for the next transfer. But don't jump onto stem cell. You need the approvals. For this procedure, we had our ethical approval, but you need to have a Department of Health Research, good laboratory practice certificate. Main important is the CDSCO, Central Drug Standard Control Organization, where there will be an inspection. The physical structure of the stem cells app should be accordingly. And then they will give you that, okay, you can use bone marrow stem cells for reproductive purpose only. These are the mandatories that you need to follow. In India, stem cells has been approved for tau, peripheral osteoarthritis, and this limbal cell, we were the first in the world. These are the approval certificate. These are the ready-made stem cell products that are available. But better to prepare because we have a coming in a big way. We also do an intrauterine scaffolding. Right now, we are using
Ma'am, your voice is and your video is frozen, ma'am.
We'll just wait for a minute, ma'am.
Yeah.
I think ma'am will be rejoining. Just give us 2 minutes, please. Okay, I think by the time ma'am joins, I'll just post a quiz. I'll be launching a quiz. You all can attempt to answer it. The answers will be anonymous. This is just to see how much we have understood. We'll have the discussion once ma'am joins.
You've shared the quiz questions?
Yes, ma'am, it's on the screen.
Is it visible to all? I'm not able to
Yeah,
see.
ma'am, people are answering it.
Yeah.
I think from phone it may not be visible. Madam is joining.
Sorry, there were some net issues.
No problem, ma'am. We thought it might take some time, so we just launched a quiz based on your.
Yeah, you can
ma'am.
start with that. I'll see the answers.
So usually we just give them about 5 minutes, ma'am, to answer the questions. Ma'am, do you have any more of your presentation left, ma'am? Were you on your last slide?
Future
Yeah.
perspectives, madam was showing that, I think.
It got stuck there, ma'am.
Yeah, that's when I got stuck.
Shall we take the questions on the chat box, ma'am, then?
Yeah, please do that. I'm already answering one.
Okay. So the first question is, what is the chemical activation of platelets? Please stop proper protocol, please.
Ma'am, are you able to hear us?
Yeah.
Yeah.
I'm just listening. So they are going to answer another.
No, ma'am, though I'm.
No, actually, these are the questions which are there
What
in the
is the
chat box.
question?
What is the chemical activation of platelets?
Calcium, the calcium gluconate vial that's available. That is the chemical activator, but we use the physical only.
Which is better, ma'am? When we use the manual method, when we use the ACG tubes.
I think the physical is better.
Okay, ma'am. But generally, freeze-thaw protocol will give you better activation.
Results.
Okay.
It just takes hardly 3-4 minutes, 5 minutes.
Okay. And in thin endometrium, what is the protocol you follow, ma'am?
Thin endometrium, look, we start with the natural cycle, or if it's an hormonal cycle. Nowadays we use rarely valerate, but if we use valerate, then we change over to hemihydrate. Then we see that we can change the route. Either transdermal is also very good and transvaginal is also very good.
No, ma'am.
Okay.
PRP protocol for thin endometrium.
PRP. After that, it does not happen. Then we suggest the PRP. PRP, when we know the endometrium is always very thin, we would start from day 4, day 5 itself. Once she stops menstruating, we will start the first one. And then evaluate the lining after 4 days, and then every alternate day. We do up to even 3 PRPs in one same follicular phase of the patient, but every time new is prepared, we do not put it in the fridge and use it again. No. But if we do PBM, peripheral blood mesenchymal stem cells, it is giving excellent result. There the protocol is different. Nowadays, more and more papers we will see on PB MSC. So there, the peripheral blood mesenchymal stem cells, we also activate little with HCG, and then we inject it 3 times. But there the blood has to be stored, and then after 2 days activated, and then 3 vials we prepare from the same collection of the blood. And then if the PRP also, we give a lot of peripheral vasodilators also to increase the blood flow along with it.
Okay. What are the potential?
But normally one is sufficing if the endometrium is like just between 6 and 7. But if it's persistently low, even in endometrial fluid, we do even 2 times in follicular phase if we see the endometrial fluid.
Okay. Are there any potential long-term or short-term side effects of using stem cell therapy?
Not really, because these don't have any tumorigenicity effect.
And how do we ensure quality control, ma'am, of stem cells or PRP? Should we measure the platelet concentration before and after preparation?
Yes.
Is it practically possible?
Yes, it is possible. You just give a little drop of it to the pathology lab if you have in-house. They will immediately see. They'll call you, what is this? This is a huge concentration. We say it is a prepared stem PRP. That's why it's like that. In stem cells, we count the number of cells, mesenchymal cells.
So for routinely all PRPs, you check, ma'am?
Yes, we do check. We
And
have to document.
ideally, it should be like 4 to 6 times the pre-preparation phase?
Yes. Minimum 3 times.
Minimum 3 times. Okay, ma'am. And how many times stem cells can be done in the ovary?
I mean, stem cells we do generally 1. If we need another dose, we would prefer to go with PRP then. Okay. But very rarely we do the second time. I think hardly Very few patient, handful of patients we do again. Because there are a number of protocols we do every month at every egg retrieval. So it is not correct. If you have done it in a proper technique and if it's going to be effective, it is going to be the first time itself.
Your talk was very insightful on especially when the AMH is so low, even in advanced maternal age, they are having their own biological child. It's something really to be inspired, and we should attempt all possible methods to give them their own gametes for
Yeah,
pregnancy.
when
But
they are so
it
adamant.
is it is quite a challenge, no, ma'am. When the advanced maternal age, when the AMH is 0.01 or 0.1, even if we are going to do a oocyte rejuvenation, ovarian rejuvenation, what is going to be the aneuploidy in the oocytes? What kind of counseling are
Yeah,
we going
so
to give
now
to
they
the
are
patient?
selling the stem cells can extrapolate as a gene therapy also. You saw in that 47-year-old. This 41-year-old is still trying. She came to us, we started first IVF, 3 eggs, none reached blastocyst. Second time she said do a fresh transfer on day 3. We did, she conceived. She's now 43 running, 42 complete, yeah. But she had a miscarriage and the product of conception showed multiple abnormalities. Then she said, now keep collecting the embryos. We did PGT and normal 1, and that transferred, it failed. Now we have collected 2 more, and today, day 3, we had 3 A-grade embryos. She's going to collect till she gets 4, 5 blastocysts, out of which 2, 3 are normal. Then we do a hysteroscopy, and then we'll transfer in her again. So there are patients who stay for 1 year from US and they want to have their own child because there these therapies are not very prevalent.
So, what is your usual protocol, ma'am? Inclusion and exclusion criteria? What kind of rigorous counseling these people go through before all these
There are
procedures?
special forms also, this consent form. They have to be told it is experimental. They have to be given all the literature if they are educated. We are just trying. And every sentence, other sentence should be ideally you should go for donor oocytes. Ideally you should go for donor oocytes. But because you want to do it, we are doing it. Not all patients are successful. Whatever success stories we can say, and we can say equally patients will have not been successful. But still they want to try. And to our surprise, when the patient gives up after failed IVF, they conceive naturally. So there is a role of regenerative medicine for such type of patients who just want to use their eggs or they don't want a child for them. You can advise adoption, whatever you want. But if they want to have their own eggs, then this is the last resort and you should offer to them with proper
So, very
consent.
important is put it in paper, counsel them, the evidence,
Yes,
the
yes.
experimental nature of the procedure, and then take their
There are
consent.
10-20% who will get converted to donor egg after one cycle. Good. Because
Yeah.
we want to tell them that donor egg is the ideal for you. We have to tell that.
Dr. Ramaraju sir has given his expert this thing about your this thing, ma'am. Dr. Nayana Patel has been a trailblazer in reproductive medicine, transforming lives with her vision, compassion, and pioneering work in fertility care. Sir has shared this message for you, ma'am.
Thank you. Thank you. It's so important and so good to get it from Dr. Ramaraju, a very good friend of mine. And he himself is like research scientist, not a gynec, I would say second, but first he's a research scientist and then he's a reproductive medicine specialist. Everything excellent.
Ma'am, what is better, PRP or bone marrow injection before IUI or embryo transfer? You're using it for IUI is something, an eye opener for all of us because we want it as cost effective as possible. But when they can avoid an IVF, why not, do an IUI and, get the
So,
benefit out of it is something.
yeah, so in IUI, it's always PRP when intrauterine infusion, because for that you don't want to do an invasive procedure like stem cell. Only we do it for subendo PRP sometimes. Majority of the subendo PRP are with hysteroscopically, subendometrially, majority of the time it is PRP. But in certain cases, only we do stem cell. And mainly the stem cells are for uterine artery, spiral arterioles. About 20%, I would say, hysteroscopic. And IUI, purely we do PRP only before intrauterine insemination. When we infuse it only in the uterine cavity, it's PRP.
Okay. And hysteroscopic PRP versus intrauterine infusion, what is your patient selection? Which group of patients will go for intrauterine? Which group will go for hysteroscopic PRP? And which phase of the cycle will you do hysteroscopic PRP, ma'am?
Look, hysteroscopic PRP, ideally, we would prefer to do it post-menstrually around 9th, 10th day. You can see the two walls little separating, a triple line coming up. Whenever the lining is good and the receptivity is an issue, I would prefer just intrauterine infusion. But if the lining is not coming up, or it's a patchy lining, or there is recurrent fluid inside, that time I would definitely once go and do a cleanup surgery with hysteroscopy and do sub-endo PRP, especially the blood flow. Even we have seen that the resistance of the uterine artery, PIRI, is high in patients where you are planning an embryo transfer. The lining has developed, texture is good, but RIPI is high. Just go and do one intrauterine infusion of the PRP and then see the patient, because as soon as you inject a properly done PRP inside the uterus, and then after 1 hour, 2 hour, whenever the patient goes, you see the subendometrial, endometrial flow is also improved, and the RIPI of the uterine artery has also improved. So that is one more indication where we use PRP, even if the lining is good, but there is blood color Dopplers are abnormal.
Very nice point, ma'am. Color Dopplers you do at the start of progesterone and then decide for
Yes,
this thing.
if it's, yeah.
So if you take a PI of cutoff of less than 2.5, or you take it up to 3?
Normally 3,
Mm.
and 1. All right.
Okay. Is there any change in the stimulation protocol after rejuvenation therapy, ma'am?
Not really, but after the EVA technique, definitely we go purely for FSH stimulation, because these patients will normally have a very high LH. So we don't want the high LH. We want to keep the LH anywhere less than 10 all throughout stimulation. And FSH can go up to 20, 30. That should be good while stimulating. And estradiol naturally increases. So for these patients above 40, we prefer pure recombinant FSH. But between 35 to 40, we go for more of FSH plus LH both. And the stimulation will be, if we are collecting oocytes, sometimes we go for letrozole and HMG therapy also, because we know 4 follicles. We have seen all 4 growing equally. And we just give letrozole, call after 6 days and see that, yes, all 4 are growing. Then simple HMG of 150 or 225. So when we are pooling 1 or 2 cycles or 3 maximum, we do conventional. Then we switch over to this. And the patients are not affording, still they want to do, then clomiphene or letrozole plus HMG or REC FSH is the ideal, because the number of injections go down.
I think madam is one delegate that asked, do you use liquid nitrogen or this thing for freeze-stop PRP activation? It's only liquid nitrogen, and
yes,
usually 15 minutes prior to the procedure, ma'am, is what you mentioned.
Yeah, just when the patient is taken in the operation theater, you start that procedure. So by the time it's ready, the cells are already activated, the platelet-rich plasma is activated, and you take inside the OT, whether it's the PRP or ovarian rejuvenation or endometrial, whatever.
It's wonderful to know platelet regenerative medicines in PCOS, endometriosis.
Yes,
it's all really wonderful. And your work on PCOS
papers.
patients. What is the phenotype of PCOS in which this really works, ma'am? Because you did LOD and also you did PRP in the ovary.
Normally,
So which group of patients?
of PCOS, this will work in all categories. Look, ideally, we feel that the laparoscopy will work when the AMH is less than 7, BMI is less, BMI is high, you don't do it. So these are definitely good prognosis patients that we have. But the bad prognosis patients, like very high BMI, very high AMH, and you can see a ovary full of stroma only, and the very packed. So these patients, even LOD is not going to help. And this procedure may also not help. But there are certain group of patients where I think phenotype classic, this results may not be good. I have to analyze our results when we have used in classic. But definitely in phenotype C, phenotype D, this could be helpful. And in B, maybe.
Okay. Sindhu, I request you to please share the poll answers before madam takes us through the last few slides which she's having.
Yes, ma'am. So the poll results, I've just shared the results. So adult stem cells are, the correct answer is multipotent. 47% have answered it correctly. Advantages of mesenchymal stem cells are all of the following except. So they don't raise ethical concerns actually. So they raise ethical concerns is the incorrect answer. And ovarian rejuvenation is useful for all of the above. Like ma'am had in her elaborate slide, primary ovarian insufficiency, decreased ovarian reserve, and for a lot more indications. So all of the above. Human mesenchymal stem cells help PCO women by suppressing Th1 response. 52% have answered it correctly, which means I think everybody has paid attention. And method to instill stem cell in endometrium is all of the above, by intrauterine, subendometrial, and directly into the uterine artery by spiral artery. So I think that's great, ma'am.
Thanks, ma'am.
Thank you. Thank you so much. And you have arranged it so well that everybody can also understand the question and get the answer to it. Yes.
Thank you, ma'am. Is there any other slides, ma'am? Or we have a lot of other questions. We would share it to your email, ma'am, at your free time. Please do guide us. And also, if people have asked about your protocol for preparing PRP, do share it with us so that we can share it with other people.
I'll share the protocol.
And we are so honored to have you, have your precious time on a weekday. You spent so much time with all of us and given us lots of insights on regenerative medicine in ART. My one last question to you, since you always innovate, try newer things, have you tried regenerative medicine in severe male factor or azoospermia?
Yes. We are doing it routinely, PRP as well as stem cell therapy. We started doing it ultrasound guided because RT test is surrounding that only you have to inject. That is the area. But it's very difficult. So we do it intratesticular and in the subscrotal skin. That is the two places. And in two cases of micro TC, when we had opened it, surrounding the RT testes, we have injected stem cells. Both of them have not given good results, but we are going to still try in that. But oligoasthenoteratosis, these were the patients of non-obstructive, the micro TC. Oligoasthenoteratosis, bone marrow derived stem cells gives very good results when you just try to inject it in intratesticular, subscrotal, and on the ultrasound, whatever little you get with that RT testis view, it's very difficult, you can inject there. And oligoastheno, it definitely gives results in 3 months with, of course, lifestyle changes and the supplements.
Thank you so much, ma'am. Actually, thank you so much. Thanks all the delegates for being a part of this masterclass series, and we really appreciate your feedback. And again, once again, a great privilege and honor to have you, ma'am. Thank you so much for accepting our invitation.
Thank you. Thank you. Thank you.
Thank you, ma'am.
Yeah, sure.